Invite the next speaker up. It's Dr. Sylvia Gothberg, who comes from the Queen Sylvia Children's Hospital in Gothberg, Sweden, where she is the director of the PICU. She's going to talk to you about mechanical interventions and their influence in cardiopulmonary interaction. Welcome.
Mr. Chairman, ladies and gentlemen, I think I'll stick this on so that I don't have to be... I'd like to thank the organizers of this symposium for inviting me to speak about the mechanical interventions and their influence on cardiopulmonary interactions. We are all dependent on oxygen delivery, and we have a fascinating and complex system to deliver oxygen to our body and emit the carbon dioxide from our body, and thus reach the goals of oxygen and carbon dioxide balance. The same system is involved in the acid-base balance and also involves parts of our metabolism. In some species, it is also important for regulation of body temperature. Important factors for the system to deliver oxygen to our tissues are the breathing capacity, a complex collaboration of our brain, peripheral receptors, and muscular activity. The alveolar capillary interaction in the lungs need a close anatomical relationship between the air and the capillaries for the optimal uptake of oxygen. For this, we need the alveoli to be well recruited and stabilized with surfactant. The ventilation and perfusion need to be well matched. The pumping capacity, an effective pump, the heart, produce the blood pressure and cardiac output to deliver the oxygenated blood out to all parts of our body through the circulatory system to the periphery, where the diffusion capacity is dependent on cardiac output, a close anatomical relationship between capillaries and the cells, the oxygen saturation, pH, and the hemoglobin value in the blood. When these factors fail, we need ventilatory and/or circulatory support to sustain oxygen delivery. The circulatory system, as John has pointed out, could be described as two pumps: the right heart and the left heart, in series and enclosed within a common chamber, the thorax, with a continuously changing pleural pressure. The reservoir for filling of the right heart lies outside the thorax and is subject to atmospheric pressure, while the reservoir for the left heart filling is inside the thorax, and the fluctuations in pleural pressure during the respiratory cycle will affect the output from the pump. The two pumps, the right and left ventricles, share a common septum and have fibers that interconnect the ventricles. The contractility of one ventricle will be reflected in the other, and the so-called ventricular interdependence. Changes in lung volume will alter the caliber of the pulmonary vascular bed and change the pulmonary vascular resistance, and thus influence the right ventricular afterload. With spontaneous respiration and normal cardiovascular physiology, the output of the left and right ventricle is balanced. The goal of all ventilation is to sustain the functional residual capacity, the FRC, which serves as a buffer to minimize the cyclic changes in PCO2 and PO2 in the blood during every breath. Relatively few alveoli collapse during normal breathing. The opening pressure is 30 to 40 centimeters of water to re-expand collapsed lungs, and 4 to 6 centimeters of positive end expiratory pressure, PEEP, is enough to sustain FRC normally. We have learned that it is important to sustain the FRC and thus stay over the lower inflection point during ventilatory support. This is achieved through the setting of PEEP so that the lung volume is kept above this point at all times. The cyclic stretch trauma in the alveoli will be less when the alveoli are kept open, and this is suggested to reduce the ventilatory-induced lung injury. In the upper end of the curve, it is important to reduce overinflation and stay beneath the upper inflection point. The best ventilation is achieved in the safe zone, where a low pressure change. A low pressure change yields a great volume change. The next step in our understanding of how to reduce ventilatory trauma is to try to move to the deflation limb and make use of the hysteresis of the lung, and further reduce the amount of pressure needed to sustain the volume for good oxygenation. Thus, we should always try to recruit the lung and then reduce the pressures and ventilate on the deflation limb. If the lung is lost, the lung volume is lost at disconnection or suctioning, a new recruitment maneuver may be needed. The deflation limb and the predicted total lung capacity is different depending on the properties of the lung. The emphysematic lung has a pathologically high compliance by the loss of functioning elastic fibers and thus a low elastic recoil. The compliance of the interstitial fibrotic lung is decreased and the elastic recoil is abnormally increased. The infant's lung has a high compliance, probably because of absent or poorly developed elastic fibers. The outward recoil of the chest is at the same time small. These two factors make the infant lung prone to airway closure. Small children compensate this with a high breathing frequency. They terminate their expiration and start the new inspiration above FRC, thus generating an intrinsic PEEP. In the early postnatal period, the babies establish airspace in the lungs through glottic closure, thus generating an intrinsic PEEP during expiration, the so-called grunting. In this picture, the relation between pressure and volume is shown for the inflation and deflation of lungs of term and preterm lambs. The unknown gas volume on the y-axis is inflated into and deflated out of the lungs of term and preterm lambs, the term and the preterm lambs. The resulting mean airway pressure is registered on the x-axis. The corresponding volume, as measured by respiratory inductance plethysmography, is shown on the second y-axis. The hysteresis of the lung is clearly shown with a much greater volume for the same pressure on the deflation limb than on the inflation limb. This means that the pressure corresponding to the same volume is much lower on the deflation limb than on the inflation limb. This can also be shown in the preterm lambs with a greater volume and a lower pressure for the same volume. There are several methods to improve alveolar recruitment and thus oxygenation. I will start with a conventional ventilation, which takes me to the Lachmann procedure. It has been established that atelectasis need to be open to reduce leukocyte infiltration and ventilator-induced lung injury. Lachmann has described a method for the opening of atelectatic lungs, which reduce the damage from continuous expansion and collapse of alveoli during the respiratory cycle. His procedure should only be performed under pressure control ventilation and does not include treatment of severe obstructive disease. The process includes titrating a peak inspiratory pressure and a positive end expiratory pressure, and then perform a reduction of pressures, still keeping the lung opened, and maintain the gas exchange at the smallest possible pressure amplitude. In inhomogeneous lung disease, intrinsic PEEP is superior to static PEEP, and it is titrated with either a prolonged inspiratory time or a high respiratory rate, like the breathing pattern in small babies. The patient may become hemodynamically compromised during the opening procedure. It is important to maintain a sufficient intravascular volume, and it may be necessary to give inotropic support. The procedure has been described in detail in adults, but not yet in children. In adults at an IE ratio of 1:1, PEEP and PEEP levels are increased in increments of 3 to 5 centimeters of water, with frequent measurements of arterial blood gases. When further increase in pressure does not result in a parallel increase in PaO2, pressures are carefully reduced until the critical level of pressure is reached when the PaO2 decreases. Thus, the opening pressure and the closing pressure are established. Inspiratory pressures are then increased to the opening pressure for a short period and then reduced to a level 2 to 3 centimeters above the closing pressure. It is favorable with intrinsic PEEP, and thus the typical respiratory rate in adults is set to 40 breaths per minute. The tidal volumes will be small. A healthy adult lung, which have become atelectatic lying in the supine position during surgery and anesthesia, does not need this procedure. This lung can be recruited with 40 centimeters of water for 2 to 3 minutes. The PEEP should never be under 5 centimeters of water due to Lachmann. Which pressures we could safely use in the pediatric intensive care in different age groups is yet to be established. The employment of a ventilation with recruitment and preservation of lung volume with high PEEP and fast respiratory rate in adults resembles what the pediatric intensivists achieve with high-frequency oscillatory ventilation. We measured the thoracic gas volume and corresponding PaO2 in term lamps during a recruitment and de-recruitment maneuver. The volume was measured with RIP technology, and PEEP was increased in increments of 5, while on pressure-regulated volume-controlled ventilation. In these animals, we registered a parallel increase in PaO2 up to 10 centimeters of water, parallel with the lung volume increase. Above that, the circulation was compromised and the oxygenation decreased. Immediately after recruitment, the lungs were de-recruited with decreasing PEEP. The hysteresis of the lungs could be shown both in lung volume, which is greater on the deflation limb, and PaO2, which is greater on the deflation limb. We performed the same procedure with recruitment maneuver measuring PaO2 and thoracic gas volume in turn lamps on HFOV, with changes instead in mean airway pressure. As with conventional ventilation, the hysteresis of the lungs could be shown both in lung volume and in PaO2. The measurement of thoracic gas volume could be one easy way to establish the opening and closing volume and then be able to ventilate HFOV patients on the deflation limb and thus minimize the mean airway pressure. Then we could use different liquids for recruitment. First, surfactant, which is present from the 28th week in the amnion fluid. We are well acquainted with the use of surfactant in the preterm babies. Their lack of functioning surfactant is easy to understand. In the meconium aspiration syndrome, the surfactant is inactivated through the inflammation, the protein leakage, hypoperfusion. The use of surfactant in this patient group is increasing, although randomized studies establishing the optimal dose and dose interval has not yet been presented. Probably the same mechanisms are at hand in ARDS, and thus the use of surfactant would be of help to open the atelectatic lung with less pressures. Randomized studies are on their way in the adult population, and hopefully the same can be performed in children. This figure shows the pressure volume curves in preterm lamps before and 30 minutes after surfactant installation. The curve is moved left. Less pressures are needed for the same volume, both on the inflation limb and on the deflation limb. These are pictures from the internet and the Michigan liquid program showing X-ray pictures as they are seen after liquid installation. While the lungs are filled with liquid, it will be difficult to see changes in the lung parenchyma with an ordinary X-ray. We performed a study in very preterm lambs, 115 to 118 days gestation, where the lambs were ventilated on conventional pressure ventilation for 2 hours, after which they were in respiratory distress. They were then switched over to rescue treatment with partial liquid ventilation, PLV, or HFOV, or HFOV plus PLV. One group stayed on conventional treatment as a control group. The effects on mean airway pressure is seen in this figure. When conventional ventilation or high-frequency oscillatory ventilation was combined with PLV, there was a significant decrease in mean airway pressure in both conventional ventilation and high-frequency oscillatory ventilation. In many patients, the FRC can be sustained with non-invasive ventilation. Continuous positive airway pressure is a well-established method in preterm babies prone to airway closure, but can be equally effective in older children. After certain postoperative cardiac procedures like the Fontan or bidirectional Glenn, the patients depend on their venous return. The pleural pressure can augment or decrease the flow into the lungs. The pleural inspiratory pressure, as John has told us, during spontaneous breathing is negative and will suction blood back into the thorax from the systemic compartment and thus increase the output from the ventricle. If positive pressure ventilation is applied, this will reduce the venous return and thus the output from the ventricle. Studies from the Royal Brompton Hospital in London have shown that negative pressure ventilation with a Hayek external high-frequency oscillator could significantly improve the cardiac output with 46% after right heart surgery. If positive pressure ventilation isn't good for the venous return in the right heart failure, it has the opposite effect in the left heart failure. For example, in the patient with acute myocarditis, a reduction in afterload is very important. To understand how positive pressure might benefit the left ventricle, we only have to do what Desmond Bourne has taught me. We only have to do the maths. He said it several times. This is his example where the afterload is presented as transmural pressure. The afterload at the same systemic pressure of 150 millimeters of mercury at minus 15 of pleural pressure in spontaneous breathing, which will be added to 150, is compared with plus 15 of pleural pressure under positive pressure ventilation, which will reduce the afterload and thus increase the cardiac output. So positive pressure breathing is valuable, preferably initiated as CPAP in the acute situation when anesthesia and intubation is risky. CPAP can be instituted also in children if done gentle and stepwise. We need to optimize the systemic and pulmonary circulation to reach the goal of oxygenation in the tissues. We want to optimize the ventilation, where the right and left heart performance is acknowledged. And we might need to use inotropes to improve the pump function, perhaps in combination with the vasodilators to reduce the systemic vascular resistance. We could further improve oxygenation with selective pulmonary vasodilators and reduce the mismatch of ventilation and perfusion in the sick lung. Selective vasodilation of the pulmonary vasculature with nitric oxide has now been at hand since 1992. In the future, we might exchange this gas and use the intravenous or oral route instead to increase cyclic GMP and relaxation in the vascular smooth muscle. This figure shows the response to nitric oxide after rescue treatment of preterm lambs with respiratory distress syndrome. This was the final part of the study with 20 preterm lambs rescued after 2 hours on conventional ventilation when they were in respiratory distress. Nitric oxide was given after the recruitment therapy, and PaO2 was raised better in the HFOV groups than in the conventional groups. HFOV plus PLV group was best at 15 minutes. After 30 minutes, HFOV plus PLV was still better than the conventional group, and CV only was the worst. Thus, NO can be used as an indicator of good recruitment. Treating patients with pulmonary hypertension and/or respiratory failure with nitric oxide might give us the possibility to reduce oxygen and thus oxygen trauma to the lung. Nitric oxide increases cyclic GMP in the cell. When patients are on ventilatory support, nitric oxide is nowadays relatively easy to administer into the circuit. But often enough, we would like to extubate and not need to give a gas, but still have the selective pulmonary vasodilation. This might be possible in the future as selective cyclic GMP specific phosphodiesterases type 5 have been manufactured. When we infused one of these new drugs, E4021, from Eisai, Japan, into the superior vena cava, that's the blue line, and compared that with an infusion directly into the left pulmonary artery in the fetal lamb, the decrease in PVR was the same. The systemic effects were minor, and we possibly have a drug that is selective for the pulmonary circulation given intravenously or orally. So, in conclusion, when we work with a ventilator, especially when the lung or the heart is very sick, we need to remember the ventricular interdependence in the heart. We have to support the two pumps at all time. We have to remember the cardiopulmonary interactions as the heart and lung share the same room. We have to remember the mechanical forces that we impose on this system when ventilatory support is needed. To optimize ventilation and oxygen transport, we have to recruit the lung and keep the lung open and support the circulation, individualize the treatment, and combine available treatment modalities. I would like to thank you for your attention. And also, I would like to suggest two excellent references for further reading. Etsuro Motoyama's chapter in Smith's Anesthesia for Infants and Children, and Desmond Bone's chapter in Pediatric Cardiac Critical Care Medicine. Thank you.